I'm here to talk to you about using the Mini-Cog to assess cognition, and it's also known as the clock drawing test. Has anyone familiar with this? So our learning objectives for today. So to find out when the Mini-Cog is most useful, to describe the advantages and disadvantages of this screening tool, to practice administering the Mini-Cog and interpreting the results, and then finally to design a script using person-centered language to explain the results and suggest next steps. So as a gerontologist, I can't help but telling you a little bit about brain aging. So our brain ages just like the rest of our body, right? The brain is an organ. We often say what's good for the heart is good for the brain. And cognitive aging is not a disease. It's a natural, lifelong process that we will all experience. And there are factors that influence our rate of cognitive aging, things like genetics or culture, education, medical conditions, acute illness, physical level of activity, and other health behaviors. So cognitive aging is different for everyone and actually begins in the womb, right? Because in the early years of life, the brain is forming more than 1 million new neural connections every second. By the age of 6, the size of the brain has increased to about 90% of its total volume as an adult. So that's where those childhood influences and experiences can come into play. And then in our 30s and 40s, when those gray hairs start to appear, the brain starts to shrink. And there are changes in how our brain works as we age. So for example, processing information, how quickly we can retrieve that information, appears to peak around age 18 or 19 and then starts to decline. Meanwhile, your short-term memory continues to improve until the ripe old age of 25, and then it levels off and starts to decline around the age of 35. So overall, as you age, you might find some difficulty or challenges with multitasking, holding information in mind. As Eileen said, you walk into a room and say, what did I come in here for, right? Or word finding, that's common as older people will note that give me a second to recall that name. So research indicates that these age-related changes in brain structure are such as a decreased size of the hippocampus or the frontal or the temporal lobes is probably why we see these changes happen. But it's important to know that new neural connections can form at any age, so we're never too old to learn something new. And this is also true with people with dementia or other cognitive challenges. They can learn new things. It might take them longer, more repetitions. You need to be patient, but they've demonstrated well into the 80s that people can form new connections. So some cognitive functions do improve with age. And you might say, okay, what are those? But wisdom, knowledge increases with age. The size of vocabulary usually increases, and reading and verbal reasoning skills also improve. Happiness follows a U-shaped curve, with people reporting they are happiest when they're in the youth, less happy in mid-life, and then become happy again towards later life. So levels of stress, worry, and anger often decline with increasing age. And I think that comes from experience. You don't worry as much because you may have already experienced something similar. You realize that life is fleeting and situations are transient and things are always in flux. So that's my explanation. But we can take steps to improve our cognitive health. And I go by the 3 E's. Because crossword puzzles aren't fun for everybody. They always say crossword puzzles, Sudoku. Well, what if you don't really like those? They're not likely to help you if you don't enjoy doing it so much. So the 3 E's are E for experience. And that's acquiring knowledge through doing things. So doing new and different things that you haven't done before. That's a great way to build those new neural connections. E for expertise, and that's knowledge from practice and study. So I think of the piano or learning a language where it's progressively more difficult, but yet you're building upon your previous knowledge. And the last one is E for environmental, and that's supports, like making lists or setting reminders or cueing next steps for people that might have cognitive issues. And those can all help compensate for the declines in cognition that might occur. So let's think about what cognitive health looks like at age 35. How would you describe that? How about 65? How about 85? Well, is it the same for everyone? No, it's not, is it? I heard a comment this morning. She was talking about working at the Veterans Association and the couple that said, I'm the brains and he's the body. You know, someone is doing really well physically, but maybe not so good with the cognitive issues. And that's the challenge, is cognitive aging is not easily defined because there are so many factors that play into that: occupation, education, environmental context, health variables, medications, depression or delirium influence how well we might do on an assessment and what's normal for a particular chronological age. So that's the challenge. So, and we learned there are gaps in assessment. Eileen talked a little bit about that, but many people who've lost a loved one to dementia often tell a similar story, that the diagnosis was delivered well after symptoms were apparent. Dementia is often underdiagnosed or diagnosed in the later stages. As many as 50% of adults with dementia are never diagnosed. One key reason for that inadequate detection is a mismatch in expectations. So one Alzheimer's Association survey revealed that about 82% of older adults believe it's important to have their memory and thinking checked, but only 16% have actually done so. Almost everyone, 93%, say they trust their doctor to recommend testing when it's necessary for memory problems, but less than half of doctors say that it's their standard protocol to do so. A lack of training is another issue. Many physicians say they've had very little training in dementia diagnoses and care. The annual wellness visit for Medicare is really supposed to include cognitive screenings, but there's no checklist on how to do that. Everyone kind of sets their own protocol with whether or not it is reimbursable, but it takes more time. So about half of adults over 65 say they have an annual wellness visit, so not everyone goes. Some people don't even know about it. I always ask that when I do screenings, did you do your annual visit? People are like, what? I'm like, that should be covered, right? But only about 33% of people say they've ever had a structured cognitive assessment, other than the doctor saying, how you doing? You know, how's your memory? That's not a structured assessment, right? So even though there's clear guidance that screenings should be offered, it doesn't always happen. And according to the guidelines, it's any visit, not just a wellness visit. There should be a cognitive screening. So why would you want to get checked? A lot of people ask that question. Eileen talked a little bit about accessing treatment options, participating in clinical trials. It may relieve anxiety to actually have a diagnosis, and people that are worried about it, then they have time to really address the situation with their loved one, to accomplish things they've always wanted to do. Kind of gives you that push to attack your bucket list, right? There might be a peace of mind that you get when you express your wishes about how your legal, financial, and end-of-life decisions will go. And sometimes costs may be reduced with good planning, trying to avoid hospitalizations or the high costs of long-term care by building that support team. And even problems with driving and safety are examples of two things that can be addressed that might prevent those avoidable crises. Like even in my mom's situation, she's 90 this year, she's cognitively very healthy, but in the last 3 years, she's had a major hospitalization due to tripping over the dog, doing things outside in the yard that caused her to fracture her hip, losing, she felt funny and got on a bed and broke a rib. And, so things like that, if you can have some safety, if we had that, who would think, but foresight to really look at safety issues, that can really prevent that cascade of downward spiral that happens and provide better outcomes. So inter-rater reliability, let's talk about that. That is an important component of a cognitive assessment. It's the best assessment would yield consistency in the results, right? So high inter-rater reliability means that regardless of who is conducting the assessment, similar judgments and observations about a person's cognitive function would be made. So if the observations are consistent, that means a person's cognitive abilities have been accurately measured. So what we need to do to ensure this high inter-rater reliability when we do a non-clinical measurement assessment like the Mini-Cog that we're going to learn about, we have to provide clear guidelines for how it's done, even to the point where everyone should ask the same questions in the same way in order to get the same result. And use a standardized assessment tool, and then encourage open communication to discuss any differences between what a person thinks and how their test turned out, right? If something doesn't seem right, we should speak up. I actually did a test with someone this morning, and they were not cognitively impaired, but there was almost like a little language barrier, and they didn't do well. And I was like, trying to explain, this is why you may not have heard me correctly when I enunciated the words, so you had to repeat them back to me. There's so many things. There's assumptions about what the right answer was because I showed a picture of an incorrect drawing, and I think they were trying to mimic, they weren't paying attention, and they thought that was what the drawing should look like, and I thought, this can really be complicated, but inter-rater reliability, sticking to this plan will really help. So in your books, there's an algorithm for assessing cognition. This should happen during the annual wellness visit. So first comes a health risk assessment, and that should be asking more than just the question, how has your health been lately? It should be questions about psychosocial risks like depression or stress or anger or pain or loneliness or fatigue. Questions about behavioral risks like tobacco use or physical activity, oral health, alcohol consumption, motor vehicle safety, all those things. And then asking about any difficulty managing the IADLs, which are the complex skills we need to live alone, like taking medication or managing our finances. One thing I noticed working at a retirement community is what might happen is I noticed a lot of older gentlemen, they would stop changing their clothes or taking a shower. And otherwise they performed beautifully, but there was that attention to self-care that seemed to be the first sign in many cases. So, and the ADL is about getting into and out of bed and showering independently or even walking and climbing stairs, and importantly, using common sense for safety and emergencies. So new in the 2024 annual wellness visit is an optional social determinants of health evaluation that the provider could choose to do. And they might ask about the living environment, the access to food, employment status, education and literacy levels, family circumstances. So that's that time that if you attended our last conference when we talked about assessing health literacy, there is a diagnosis code, a billing code that providers could choose to ask about these kind of things and be reimbursed. So if signs or symptoms are present, there would be a brief cognitive assessment given, such as the Mini-Cog. That is really the one that I've always seen used. Not too much anything of these longer ones, but it's usually the Mini-Cog. And then if there's an informant or a caregiver there, they'll be asked to hopefully confirm or give more observations. I talked with someone this morning and she said, my father was a former physician and he fools everybody. He knows the test, he knows the answers. And she's like, I'm trying to say, but I'm managing his finances. I'm taking care of everything. And I said, I'm surprised that the physician never asked you, how's he really doing? I said, you need to come in and say, I've given him the Mini-Cog. He does really well, but he's not doing well with this. So it's that kind of thing happening. So if the Mini-Cog score is low, the person might be referred for a full evaluation, but that's really the preference of the provider unless the family's really asking for it. So when I went to the senior centers, I used to say, hey, you want a checkup from the neck up? And they would be like, what? What's a checkup from the neck up? The Mini-Cog. So it's a tool for seeing whether someone shows the signs of dementia. It tests cognition in a way that's been scientifically demonstrated to help determine if someone might be in a stage of Alzheimer's disease or related dementia. It's easy because it's short, just a few minutes. It's been statistically validated, so an instrument is valid if it measures what it set out to measure. And there's two parts. There's the 3-word recall test, and that assesses memory. And then the clock drawing test that assesses cognitive function, language, visual motor skills, and executive function all in one. So it also provides a powerful visual to loved ones who might be at the visit when they actually see the difficulty that a person might have. Sometimes these tests and numbers, you're like, well, what's normal, what's not? But when you see that a person can't draw the clock correctly, that's a powerful sign. So I'm going to show, it's about a 7-minute video. Someone said, well, it's pretty basic and it's scripted, but I'm intending for you to remember it because remember when you hear information through 2 channels, you're going to hear it an audio and you're going to see the visual. So instead of me standing here and talking about it, that's going to be like a double saving in your memory bank. So it'll help you to remember what to say.
Hi Colleen, it's nice to see you.
Thank you, it's good to be here.
It's been about 6 months, I think, since your last clinic visit.
Yes.
I understand from the nurse that you're here because of some dizziness that you've had recently.
Yes, I am.
Yeah, sounds pretty bothersome.
It is.
Well, before we look into that a little bit more, we're doing something new in the clinic, which is that just like the nurse was checking your vital signs, your pulse, your blood pressure, we're now also checking the health of the brain on a routine basis. Okay. And so I'm going to ask you some questions next that require a little bit of concentration. Sound okay?
Okay.
Okay. The first thing is I want you to listen carefully because I'm going to give you 3 words that I want you to repeat back to me and try to remember for later.
Okay.
You ready?
Mm-hmm.
Okay. The words are banana, sunrise, chair. Can you say those back to me?
Banana, sunrise. I don't remember the last word.
Okay. The 3 words are banana, sunrise, and chair. Can you see those back?
Banana, sunrise, and chair.
Great. Now, I'm going to give you this piece of paper with a circle on it. And what I want you to do is make a clock for me by putting in all the numbers where they go. Now, Colleen, can you set the time so it says 10 past 11? Okay, I'll take that back from you. Now, what were those 3 words that I had you repeat earlier?
sunrise, banana, shampoo.
Okay, great, thank you. Colleen, have you had any concerns about your memory recently?
Yes,
What kind of concerns?
that I'm forgetting a lot.
Okay, what kinds of things have you been forgetting?
Things that I'm supposed to do during the day that I normally do.
Mm-hmm.
Or like when I go into a room to get something, I don't remember why I'm in there.
Mm-hmm.
And then I start cleaning and doing other things, and then I remember what I went in for, and sometimes I don't.
Mm-hmm. That's really frustrating.
Very.
Well, maybe once we're done with today's visit, it might be a good idea to have you come back so that we can look into that a little bit more. Would that be okay?
Yes, that would be fine.
Okay, sounds good.
So there are some drawbacks or limitations of this tool. The first one, what do you think might happen if you're trying to assess someone who's unable to read, write, or draw, or that has low level of education, or even low vision? It'll be a false positive, right? The test will show that they have some kind of cognitive challenge when it's really attributable to something else. So the solution for that is what we talked about in the March conference, is having an assessment of health literacy. And that can be very simple in terms of making sure you use plain language, not using acronyms, but also making sure a person has a clear understanding of what you're trying to say to them and they can repeat it back to you. And in this case, you can replace that clock drawing test with a test of everyday life, like a simple subtraction problem, or a multi-step performance task, like asking them, tell me all the steps that you would use to bake a cake, or that you would use to get in the car and start the engine. And that's a way to assess cognition in a way other than it's not literacy based. Level of severity, this test does not provide any assessment as to the level of severity. That would be determined from a full cognitive evaluation. There are language barriers. I heard this from a woman who said she had been in the country for 25 years. She was nervous about having a cognitive assessment, and she said, my native language is Spanish. And she's like, so you're saying the words and I'm trying to translate them so that I can remember them better, and I got confused. And she said it was really an obstacle. So if you know that someone's first language is something other than English, there are at least 20 different languages where this assessment has been validated. So always assess someone in their first language. And then there are cultural norms. We kind of talked a little bit about this in the conference, but factors related to things like these language barriers, education, literacy, familiarity with the culture on some of those longer tests where you ask things like, what county do you live in? Well, if you're newly acculturated, you might not know the geography of the area. You might not even really know who the president is if you haven't been in the country long, or you haven't been connected to the media. So there are disparities there and challenges when you're assessing older people. So lower levels of acculturation are associated with poorer performance on tests of mental speed, even when the tests were administered in the native language and scores were corrected. So an individual might have trouble accessing health services or communicating with providers and managing their care. So there are some considerations that go with this test. You have to understand that a person might be uncomfortable or nervous in testing situations. Some people are very worried about the symptoms they're experiencing, and that not everyone trusts the expertise of clinicians, and trusting relationships take time to develop. Some people fear the stigma of a diagnosis, that they might fear unwanted or unfair treatment. And so there are cultural mismatches. together with low socioeconomic levels and historic discrimination that contribute to disparity experienced. So the solution is really that when health literacy is assessed and addressed, that these disparities often disappear. So that's where it's really important to get that extra piece to whether the person really is aware and understanding the implication of the test that you're giving. So in your program book, there is the actual Mini-Cog. The first page is the word recall portion, and the second page is for clock drawing. So if you'd like to pair up now or in small groups and practice, if you haven't practiced that yet, there is 6 versions of the test, so you can use different words. It's important to really script the way you ask the questions, the way it's scripted here, and take the steps in that order. And then there's this scoring tool. And the thing to remember about scoring is on the clock drawing, you can either score 0 or 2. There's no 1. So either you have the clock with the numbers correct and the hands in the correct positions, or you don't. So there's no way to earn a 1 point for that. It's either right or it's wrong. But thank you for trying that. So here's a couple of tips for conducting a screening. Don't use the words test because that puts people on edge. You don't really have to say memory. You could just say cognition, so that's less intimidating. Kind of maintain an easy breezy attitude. This is just a cognitive assessment. It's not a complete evaluation. Smile, be nurturing, be gentle but persistent that people complete all the requirements, and then ensure no sensory confounds are present. So hearing aids, glasses, make sure they're in working order so that people can accurately hear the words that you're giving.
Cognitive screening is well accepted. I would think that would be a little bit more invasive than, just a test or something.
Yeah, a cognitive screening, because I think they should understand the importance of it. So we went through these.
That sounds like fancy words to me.
Yeah, I know. That's not, I would say a checkup from the neck up. That's all you have to say.
You gotta make it funny because cognitive is like, oh my God, they're gonna die.
That's a big word, yeah. I agree. But you can call it what it is, too. So you might want to screen for a mood disturbance, like how someone is actually doing that day. Don't allow someone to give up or skip questions. Stick to the questions and use the terminology that is given. Say the words the way they are on the test. Don't offer multiple choice. Be strict on deducting points. And I've had people not do well, and I could say, there are reasons why you might not do well. It's not that you have dementia today, but maybe you're tired today or your medication side effects. So kind of reassure that this is not a diagnosis of dementia. So when you're communicating the results, we want to use a person-centered approach. And so that means to be sensitive to people. You would anticipate that if someone doesn't do well on this, it might be shocking or surprising, or there might be other emotions that come out. So a person with dementia might have a little difficulty actually processing what you're saying, so you might want to give them a little bit of time to react and articulate their feelings or their questions, and respond with empathy, and be sure they know that you've heard their concerns. Try to provide honest answers or resources that they can go to for information, including the Alzheimer's Association or other support organizations you might know about in the area. Like the support groups, I think are really great. If you know of one locally, that's a good number to keep in your pocket. And then fostering that sense of hope by being positive. Each person's cognitive journey is different. Even if they've known someone, a grandparent or a parent who's had the same disease, it might not be the same journey. Many problems associated with dementia have a solution, right? And there are treatment and support options which can improve quality of life. I've heard people say, this could be the best time of my life. I'm not going to worry about whether I can remember my past. So it doesn't take away the opportunity to experience joy if you can't remember what you had for breakfast, right? That's all determined about the social interactions you have, the experiences you have in a day, and your outlook towards the future. So, and notice the caregiver. We heard a lot about that during the keynote. Ask about their questions and stress level and support needs too. So there are a couple, if you're interested in this, there's a lot of assessment tools online. I like the one, mybrainguide.org, that has a memory questionnaire and resources. And then the Cleveland Clinic has healthybrains.org. Those are just kind of interesting things you can do. If you can get someone to maybe go online and try that if they don't want to go directly to a provider for a test, that might give them a little, incentive to maybe mention a problem they're having to their physician or care provider. So thank you for all you do to serve and support others. Appreciate it.